Thanks, Sonali. Good morning, ladies and gentlemen. First of all, let me thank the organizers for giving me this opportunity. It's an honor indeed. So I thought of starting my presentation by testing your general knowledge these days. So those who can identify this country on this map, can you put your hands up? Well, yes? Can anybody tell me what this country is? Well, I'm surprised. This is Ukraine, right? So this is Crimea, the Black Sea. So what is this part that has been highlighted in red? Can anybody guess? Correct, brilliant, because Russia has occupied this area. So for me, this particular war, there's a brutal war going on, and then the repercussions could be seen all over the world. The cost of living has gone up in Europe, and Africa is starving for their wheat and other grains. So as an endocrinologist, for me, this is the anterior pituitary, and this is the posterior pituitary. So here also, when you have pituitary apoplexy, you can't brush it aside saying that it's a storm in a teacup because its ripples could be felt all over the body. And most of you are into general medicine here. So what I thought was I will hinge my presentation on 3 important messages. When would you suspect apoplexy? And the importance of giving steroids for these patients, and the timing of surgery, and how you would select the appropriate patients. So the word apoplexy, it originated from the Greek word apoplexia. It meant paralysis by a stroke, and there are different other meanings also given for that. So what I would like to emphasize is it was used to refer to a clinical syndrome because imaging was not available those days. But now when it comes to stroke, rather than saying hemiparesis or face, arm, leg palsy, we refer to frontal lobe hemorrhage or parietal lobe infarction. So the word pituitary apoplexy also has the same connotation here. It was first described in 1898 by Bailey. But later on, it was in 1950, the term apoplexy, pituitary apoplexy was coined. And initially, it referred to the clinical syndrome of sudden onset headache, visual disturbance, and altered mental status. Later, with the advent of imaging, we knew that it was caused by either hemorrhage or infarction in the pituitary. So some of the studies, they use the clinical syndrome and imaging for the definition, and some studies, they use only the imaging. And you may come across patients where there is image finding of hemorrhage, but no clinical features. So we call it subacute apoplexy, so that's beyond the purview of this talk. So the authentic guideline on this topic seems to be by Professor John was my trainer at Oxford and his team. So it was in 2010. So their definition, it says classical pituitary apoplexy refers to a clinical syndrome characterized by sudden onset headache, vomiting, visual impairment, and decreased consciousness caused by hemorrhage and or infarction of the pituitary gland. So they have taken into account the clinical syndrome and imaging to bring about this definition. So apoplexy commonly occurs in pituitary adenoma, and 80% of the time when someone presents with apoplexy, that is the first manifestation of pituitary adenoma. So therefore, you have to be very careful. But having said that, there are case reports to say that there could be hemorrhage or apoplexy into Rathke's cleft cyst, craniopharyngiomas, pituitary mets, and primitive neuroectodermal tumors. And again, this study, when you look at the epidemiology, it's a very rare condition. So again, Professor John Voss did this study in Banbury, Oxfordshire. And according to that, prevalence of apoplexy seems to be 6.2 per 100,000. And a Finnish study puts this value at 0.17. So there's a big variation there. And the average age is 50 to 60 years, and there's a male predominance. And why does it bleed inside the pituitary tumor? So generally, the pituitary gland is supplied by the hypophyseal portal system. But when it comes to a tumor, it gets its blood supply from the systemic supply, the hypophyseal arteries. Especially the inferior hypophyseal artery is more sensitive to changes in blood pressure, systemic blood pressure. And these blood vessels in these tumors are very fragile. And the tumor tends to outgrow the blood supply in certain instances. And now molecular mechanisms have been proposed, but I'm not going to elaborate on them. So they might change the way we diagnose apoplexy as well as treat apoplexy, and it might help us to prognosticate. So what are the predisposing factors for apoplexy? There's a long list, but cardiac surgery is very important because when they go on pump, there's a big variation in blood pressure and we have to heparinize a patient. So last year, there was a patient who with pituitary apoplexy adenoma had to undergo cardiac surgery. So we went for an off-pump surgery and luckily nothing happened there. And then the drugs that we use as endocrinologists can predispose to apoplexy. And then the dynamic test that we do also can predispose to apoplexy. And dengue hemorrhagic fever is quite common in Sri Lanka. But I'm yet to come across a case report. Maybe we have missed out on a few cases. So while Professor John Voss and my co-registrars were busy with the apoplexy guideline during my stay in UK at Oxford, under the guidance of our beloved trainer, Professor John Voss and Professor David Worrell and our own Dr. Henry Rajaratnam, my task was to review the effects of Russell's viper venom on the pituitary gland. So it's quite common in our country and this part of the world. So there also we showed that patients with after Russell's viper envenomation can have pituitary hemorrhage. So this is a 17-year-old farmer from Burma who has hemorrhage into his pituitary stalk, and this is another patient again from Burma where there's pituitary hemorrhage. So these photographs were from the collection Professor David Worrell had after his stay in Burma. So how do these patients present? In order to understand that, it's better for us to understand the anatomy of the pituitary and the surrounding structures. So on top you have the optic chiasm, and then well, the point is not moving. And then you have the pituitary gland. Let me go to the clinical features. So 80 to 90% of these patients, they present with headache. And then they can present with impaired level of consciousness, which also indicates the severity of the condition. And visual disturbance is also quite common because the intracellular pressure, when it's exerted on the optic nerve, it can give rise to visual disturbance. So they can have blurred vision and bitemporal hemianopia. When the lesion extends laterally, it can have its effect on the cavernous sinus, and within the cavernous sinus, you have the third, fourth, and sixth nerves. So they can come with ocular palsies. And very rarely, like in subarachnoid hemorrhage, they can present with meningism as well as stroke, along with the above clinical features. So we can't forget the pituitary gland. The intracellular pressure can cause hypopituitarism. So in this study review article, you can see from 2004 to 14, they have looked at several studies. And unlike diabetes or cardiovascular studies where they study thousands of patients, here the numbers are in 2 digits or 3 digits. So here they have shown that gonadotroph, thyrotroph, and corticotroph deficiencies are quite common. And growth hormone deficiency is also more common, but we don't test for it quite often in these patients. And diabetes insipidus also has been reported in some of these patients. Out of this, corticotroph deficiency is something that we should not ignore because it can give rise to hypotension, hyponatremia, and hypoglycemia. And there could be catastrophic consequences if we miss out on that. And some of these patients can present, according to some of the reports, only with symptoms of acute diabetes insipidus rather than headache or anything else. So here we present a case from Navalapitiya Hospital, a 39-year-old theatre nurse while being in the theater, she noticed acute onset polyuria and polydipsia. Luckily, she was not the assisting nurse at that time. She was only the running nurse. And then we diagnosed cranial DI and cortisol deficiency, and she's on hydrocortisone and desmopressin. Now I'll show you the MRI. So you can see in this T1 weighted image, there is hyperintensity of the anterior pituitary, and the posterior pituitary also there is hyperintensity. So some of you will argue anyway the pituitary may be hypointense, posterior pituitary may be hyperintense on T1, but our radiologist was very sure that looking at the size of it and the degree, there was bleeding into the posterior pituitary. So, and it correlates well with the clinical features, and it will be reported shortly. And then prolactin 2 gives us some additional information. If the prolactin is high in these patients, that will refer to, that might suggest there is torque compression, and it tells us there is viable pituitary tissue left. So they may have a better prognosis. So in this particular study, again, the numbers, they looked at patients who showed recovery of the pituitary function after apoplexy, and they compared that with patients who did not. So the numbers are 7 and 6. So that's how this condition is. So those who showed recovery of pituitary function, the prolactin level was 9.3 plus or minus 7.2. Whereas if you look at the other group, the prolactin was very low. So prolactin can give us some information. But although I'm talking about pituitary apoplexy, most of you all in the acute setting, if someone presents with headache, you have to entertain so many 101 differential diagnoses, and pituitary apoplexy is one of those, but you can't afford to miss it. So when would you suspect pituitary apoplexy? Any patient with acute onset severe headache, with or without neuroophthalmic signs, it's better to entertain this diagnosis. And meningism or other focal neurological signs do not exclude pituitary apoplexy. And how do we manage them? Again, it's a rare condition, so optimal management still remains uncertain. So when you assess the patient, you may have to focus on certain entities. There is the hemodynamic stability, the level of consciousness, the vision in terms of acuity and the field, and ocular palsies. Later, you may move to imaging, visual perimetry in a person who is able to do that, and then endocrine and biochemical evaluation. So when it comes to imaging, most of the time in the Sri Lankan context, what will be available in the acute setting is going to be CT. So if someone presents within 6 hours, CT is a better imaging modality because it picks up hemorrhage much earlier. And also it excludes subarachnoid hemorrhage, which is going to be an important differential diagnosis in this case. And macroadenoma could be excluded in 80% of patients. And MRI in the acute setting may miss it because blood may look iso-intense on MRI. But some studies have suggested if you see a mucosal thickening of the sphenoid sinus, it might give a clue to the fact that there's pituitary apoplexy. But later on, obviously, we know MRI characterizes these lesions much better than CT. So initially, you will stabilize the patient. After that, we can take either of the two pathways, surgery or conservative management. So when you stabilize the patient, you have to focus on fluid and electrolyte imbalance. And cortisol insufficiency is very common in these patients and can lead to mortality. So in addition to replacing cortisol by giving hydrocortisone, we can also bring about an anti-inflammatory effect and anti-edematous effect. So according to the UK Pituitary Apoplexy guideline, immediate administration of high-dose glucocorticoids is recommended. And they have said especially for patients who are hemodynamically unstable and who have severe neurological or neuroophthalmic signs. But you wouldn't wait for the confirmation. So take the blood sample for cortisol and then immediately give IV glucocorticoids. But some of these recent review articles, they say it's better to give hydrocortisone to all the patients empirically. I would subscribe to the second listing in the Sri Lankan context to keep it simple. So the steroid is IV hydrocortisone. We start with an IV bolus. Oral steroids are not recommended because they might come with nausea and vomiting. And you go on to continue with an IV infusion. And or you can go for intermittent IM hydrocortisone. And IV hydrocortisone is not recommended because it may not bind to cortisol binding globulin, and then it may get excreted. Dexamethasone has not been studied, but some of the neurosurgeons may prefer to use dexamethasone in order to manage the cerebral edema, but it's not generally recommended. But you have to remember, if somebody comes with apoplexy following Russell's viper envenomation, you should not go for IM hydrocortisone. You have to go for IV, otherwise you might cause a muscle hematoma because of the coagulopathy that they have. So we have recommended this in our article. So the importance of steroids, all patients should be empirically given parenteral glucocorticoids. That's my recommendation. And then some of them will have thyrotroph deficiency, but after replacing hydrocortisone, you have to go for thyroxine. So the next is whether you will go for surgery or conservative management. Still, it's controversial because we don't have RCTs, and always there's a selection bias because those who have mild disease, earlier all the patients were subject to surgery, but now there's more and more evidence to say that medical management or conservative management also has a place. So those who have milder disease are generally managed conservatively, and those who have severe disease are taken for surgery, so you can't compare the two groups. In order to make this choice, you need a multidisciplinary approach. So you need the support of a neurosurgeon, you need the support of an ophthalmologist, and you can't forget us, the endocrinologists. And when you say surgery, we talk about transsphenoidal surgery. That's the recommended surgery, except in rare cases. And when they compare the two, you have to have some outcome measures. So for these studies, the outcome measures that they have used the recovery of the vision, recovery of ocular palsies, and the recovery of hypopit, the tumor removal, and mortality. So all these are different studies, small numbers. So in this particular thing, when you compare surgery versus conservative, when it comes to vision, the conservative group seems to perform better, but definitely there's a selection bias because if they had had significant visual defects, they would have undergone surgery. And you have to remember that optic nerve has a very low tolerance to ischemia, and delay in treatment is one of the predictors of outcome. And if you do surgery within 7 to 8 days, there's a better outcome when it comes to visual field and visual acuity. So if you want to save the vision, do surgery as early as possible. And when it comes to ocular palsies, the conservative group seems to do better. Again, there's a selection bias in some of the studies. Actually, those who did not fare well on conservative treatment were operated. So therefore, you can't easily compare the two groups. So recovery was noted even with delayed surgery when it came to ocular motor nerve palsy. So ocular palsy alone may not be an indication for surgery. And when you look at recovery of pituitary function, here paradoxically the surgical group has performed better. And what they have shown is, if there was resolution of the pituitary mass after apoplexy in a conservatively management patient, there's a higher incidence of hypopituitarism in those patients. Maybe the whole pituitary would have fibrosed. And the surgical group, after surgery, the recovery, even after 2 years, you can expect recovery in these patients. And when you do surgery, there are different studies. Again, there's a significant number in the surgical group where you can expect complete resection or subtotal resection based on the competence of the surgeon. And even in the conservative group, a significant number has shown shrinkage. The mortality in the surgical group ranged from 0 to 15%, but in the conservative group, most of the studies it was 0%. But one particular study I would like to highlight, out of 6 patients who were managed conservatively, 3 have died. So they were followed between 4 to 14 days. So I'm really surprised that without sending them for surgery, they have a conservatively managed. So therefore, we have to be more careful when you select patients for conservative management. So even if you decide to manage these patients conservatively, your eyes and ears should be open, because at any moment these patients could deteriorate and you will have to rush them to the theater. So the indications for surgery, if somebody has visual field or visual acuity impairment, if there's impaired level of consciousness, you'll go for surgery. And if there's enlargement of the cellular mass and if the clinical features deteriorate, you will have to go for surgery. But if there is isolated ophthalmoplegia, that itself is not an indication for surgery, because you can expect recovery with conservative management. But to quantify these things better, again, Professor John Voss and his team, they came up with this pituitary apoplexy score. Otherwise, we don't have a quantification for this. So here they have looked at only the neuroophthalmic signs, and they have looked at the level of consciousness, visual acuity, visual fields, and ocular palsies. And based on that, they have given a grading system. So this helps us to have a uniform clinical description of these cases, and then to objectively quantify the neuroophthalmic signs, and we can compare the management options. And some of the literature, they have said if the apoplexy score is over 4, then you select for surgery. But when you looked at the retrospective study that they have done by Narendra Reddy, one of my co-SPRs at Oxford, so they looked at 54 patients, and 65% of them underwent surgery and 35% were managed conservatively. And the score, but there's a big range, I should tell you. People who were managed surgically had a score of 3.5, whereas people who are managed conservatively, the score was 1.4. So that shows that this is a good way of assessing patients. But I could not reconcile the fact that here it is 3.5 and there we have given the cutoff as 4. But a prospective study also has been done, that's what I understand, but still it has not been published. Again, Mass General, they have come up with a different scoring system. That's also quite interesting. So they look at the radiographic image findings, and if the patient has visual field defect or reduced level of consciousness, it becomes grade 5. And ocular paresis grade 4, and sudden severe headache grade 3, and endocrine symptoms grade 2, and asymptomatic grade 1. So that means here they have not looked at, to make the definition, they have not taken into account clinical features as well. So without clinical features, subclinical apoplexy also has been taken into this formula. And if they also have, if it is due to a prolactinoma, or if the patient has a Rathke's cleft cyst or other comorbidities, then although the grading is higher, you will probably think of managing them conservatively. So then that's another factor that you have to take into consideration. But otherwise, higher the grade, higher the indication for surgery. So this is a 62-year-old male who presented to our clinic with hypertension and sudden onset severe headache and vomiting, but his vision was normal, level of consciousness was fine, and the apoplexy score was 2, and he had corticotroph deficiency along with other hormone deficiency. Here you can see there's a pituitary lesion with hemorrhage there. So he was managed conservatively, and he made a good recovery. 4 months later, you can see that the lesion has resolved. And this is the lesion on presentation. You can compare the two. But he remained hypopit 10 months later. So earlier I told you, if someone's tumor resolves, there's a very high chance he will continue to have hypopituitarism. So early versus late surgery, they have looked at the visual field outcome. So there's no big difference between doing surgery within 3 days and within 7 days. But on the other hand, if you delay it further, when you compare 8 days versus 34 days, 9 to 34 days, there's a significant difference in the outcome when it comes to vision. So this is another young gentleman who came to our clinic. He had a macroprolactinoma and he was on cabergoline, presented with sudden onset severe headache. He had a normal GCS and he was hemodynamically stable. And it was Sonali who made the diagnosis, I should say. And then there was hemorrhage into the pituitary. So initially you can see there is visual field defect, and over the next 7 days it deteriorated. And then on the 14th day only we managed to do the surgery, because the patient had some effects when it comes to localizing the surgeon, because he didn't like the Kandy surgeons, he wanted one in Colombo, so it took some time. And luckily, although the surgery was done after 14 days, his visual field, it improved. And then you can see there's a very good outcome there. So this is the fat packing there. So the important message is, when you decide to manage someone conservatively, be very careful. And then you have to select the appropriate patient for surgery, and the timing is crucial. So when you look at long-term follow-up, just like after any other intervention for pituitary tumor, here also there is a chance of recurrence, and it is more in the conservative group, so therefore you need a long-term follow-up. Again, there are new techniques in the horizon, but the stereotactic aspiration of this apoplexy, that concept has been there for a very long time, and now there are some studies to see whether it could be refined. So these are the final slides. So even if your cart is still empty, don't worry, because if you focus on these three messages, it will be fine. So you suspect pituitary apoplexy in any patient who presents with acute onset severe headache, and then all patients with pituitary apoplexy should be managed with IV glucocorticoids, and don't delay or deny surgery in patients who require it. For this, you need the input of the experts. Thank you.